Good evening, everyone. Welcome to the webinar series from the Department of Emergency Medicine, Yashoda Hospitals. As with every week, we have another interesting topic today, that is ECPR. The CPR has been evolving. The guidelines from the LCOR and AHA are being updated every 5 minutes. But simple CPR may not be effective anymore, but we need to evolve it into ECPR. That is utilization of ECMO during CPR. It's not a simple thing to start ECMO. So only in high-end facilities, it's being practiced very rarely, even that. So to know more about that, we have our speaker today, Dr. Sridhar Maram. He has done his DNB from the Kerala KIMS Institute. So now after that, once he has joined Yashoda, he has also pursued his MRCEM. So today he'll be talking about ECPR, any research that's been done on this and what are the findings and all. You can ask your questions in the chat box if you have any, and they'll be answered in the end. Welcome, Dr. Sridhar. You may start sharing your screen.
Thank you, Dr. Naveen. I'm screen is, are you able to see the screen, Dr. Naveen?
It's not full screen.
I think you have to close the PPT and reopen the PPT. It will get disabled usually. Slideshow. మొత్తం క్లోజ్ చేసి మళ్ళీ రీఓపెన్ చేయండి సార్.
Okay, fine.
Yeah.
Is it okay? Yes.
Good.
Okay. Good evening, all. Today we'll discuss about the ECPR, what exactly, how it will be helpful in managing the patient about the CPR, conventional CPR. So what are the techniques, like what are the types or techniques we use for CPR is conventional manual CPR, where we use the hand for the proper CPR, and few automated mechanical CPR devices are there, UCOS and autopulse. And in few patients, even we can try open chest CPR. ECPR is extracorporeal cardiopulmonary resuscitation. So what exactly is this? Why we need to know about ECPR? Usually like conventional CPR, like while doing proper resuscitation with conventional CPR, can only deliver only 15 to 25% of normal cardiac output, which is very low flow state, which may leads to ischemic damage to the vital organs. Apart from that, like what we concentrate usually in conventional CPR is the heart and the brain. So apart from that, like vital organs also can be managed with ECPR. So ECPR can provide near normal level of cerebral and end organ perfusion. So survival rate will be more compared to conventional CPR with ECPR. So ECPR is nothing but VA ECMO resuscitation. So in this method, like what exactly we'll do in ECPR is it's a portable device called ECMO. Will connect externally to the continuation of the CPR, conventional CPR. If any patient went into cardiac arrest, we'll identify the cardiac arrest and do the proper resuscitation according to ACLS algorithm. Meanwhile, like if the patient is eligible, we connect this portable device called ECMO to that patient, and it has only the cannulation which differs. Like venous cannula, we need to secure, and arterial cannula. So in the venous cannula, oxygen pour blade from the body to enter into the machine or like generator, and it will go into the oxygen-rich membrane, where oxygenation of the blood will be there, and that oxygenated blood will pump into the body. That's how the circulation will be continuous and oxygenation will be continuous. So with this conventional CPR, only 25 to 30%, we can improve the flow in ECPR. This is how it works. So you can see the cannulas, venous cannula and the arterial cannula, that almost into the inferior vena cava is the venous cannula, and into the aorta is the arterial cannula. So deoxygenated plus poor oxygen will go into the pump. From there, it is going to the oxygenator, where there will be oxygen exchange will be there. Oxygenated blood will push into the body. And that's how it maintains the perfusion pressure, and at the center, it will perfuse end organs, like along with the heart and the brain. So this is a small video, like which we can see the live of doing the ECMO, connecting the ECMO while the patient is continuing resuscitation effort with glucose. Chest compression is going on and the airway is maintaining, and like it was like a ACLS like algorithm they're following. Meantime, they're connecting to this ECMO machine. So when is the ECPR used? Like when the like when exactly we need to think about ECPR? Well, like if any patients, if like whatever eligible criteria is there, if it is fits, we can think about the ECPR, and when we need to go at what point of resuscitation. So when the conventional CPR is ineffective, means like if you are like doing proper continuous resuscitation with the corrected algorithm, still like if you are not able to achieve the RAS, means like we can take it as 10 to 30 minutes of CPR or 3 defibrillation. Even though if you are not getting proper, like if you are not getting RAS, then we'll call it as refractory cardiac arrest. At that point of time, if the patient is eligible for the ECPR, then we need to connect it and continue the resuscitation effort. So even American Heart Associations endorse this ECPR in case specific use. Case specific, it means like in eligible candidates. So ECPR, using of ECPR is much more beneficial than like going for the conventional CPR in few cases. So who are the eligible candidates? So anyone who witnessed the arrest, a good bystander CPR, and initial rhythm is shockable, and no known major comorbidities. These are the candidates who are eligible for the ECPR. So even the healthcare provider or EMS with a proper resuscitation care, if is not getting the RAS, then we need to cannulate as early as possible in those patients. So either cannulation should be happened in the ER or cath lab. If the EMS is well enough to cannulate outside, also we can try that. So as early as cannulation is more beneficial to the patient. So after cannulation, we will get some time to identify the reversible cause. If you can identify the reversible cause, we can intervene there, we can correct it, and we'll get the ROS with intact neurological outcomes. So what are the so how we can go this, like it is difficult at present, like pre-hospital emergency settings is not up to them like as expected, and there is less community awareness. We need to community awareness in regards to proper identification of the cardiac arrest patient, and at the same time proper giving the BLS, means like proper chest compressions like CPR by the community, and availability of ECMO team with skilled doctors from the clock needed. And financial, still like NPO centers financial constraints and bystander acceptancy in regards to the prognosis, difficult to accept the or like prognosticate to the attenders. So post VA ECMO complications, most of the time the complications is the bleeding or unsuccessful cannulation or limb ischemia, and most of the time it is infection. So how to overcome all these barriers? Like we need to have robust code blue ER system, especially in hospital cardiac arrest system. If it is out of hospital cardiac arrest system, we need to robust our EMS services, and at the same time we need to have ECMO, mobile ECMO things. So active ECMO programs and training centers are like the simulation programs needed. Availability of expertise in institute with equipments and supporting team round the clock should be needed. So what exactly is the VA ECMO, or what you call as ECPR, is the only thing needed for the betterment of the patient? No, it's only the part of the chain of survival. Like it is the proper identification of a cardiac arrest patient, followed by good bystander CPR and early defibrillation, followed by is the ECMO, ECPR we need to consider, or VECMO we need to consider for the proper outcome of the patients. So what exactly, like how the team needed for a proper go, or like a proper resuscitative care along with the ECPR. So here like proper EMS, ER physicians, intensivists, and at the same time cath team. So like proper running of the code by the ER physician, and like if the patient is eligible for the ECPR, early cannulation by the intensivist or like cath lab team should be there. And if any reversible cause, like it has if it is reversible cause is acute MI, mobilizing the patient as early as possible to the cath lab with connect, like after like securing the cannula and with good flow of ECMO CPR. In few countries, they're even doing at the site. They're like cannulating the patient at the site, and like at the site means EMS. They're cannulating the patient. So how they are doing? How did they do it? Like community awareness is good, and they know the like they're using PLS very well, and at the same time they're using a AED, especially in any like VT or VF patient initial rhythms. And robust EMS and paramedics and mobile ECMOs are there, ED ECMOs, in hospital ICU ECMOs. How they coordinate each other. If any cardiac arrest patient is there, initial rhythm is VF, and if the EMS person identified that the candidate is eligible for ECPR, then they will inform the central dispatcher. There is a team called activation of mobile, like there is a mobile ECMO cannulation team will be there. They will move nearest to the nearest possible hospital, and EMS person will transfer the patient to the nearest possible hospital, where they will cannulate the thing and they will continue the resuscitation. They will identify the reversible cause. If the reversible cause is the cardiac, they will mobilize to the cardiac catheterization and followed by stabilization for the stabilization in the ECMO ICU. This is how they have the protocol in in initiation and starting the cannulation, especially planning for ECPR. So what are the pros of ECPR? It's a bridging to the treatment. It's a life-saving bridge. It will give us some time with intact organs like perfusion. End organ perfusion will be continuous, and we'll get the time to evaluate the cause of death. So reversible cause, if you identify, if you treat, we'll get the patient ROS with intact neurological outcomes. So improved outcomes like use of ECMOs are still certain benefits for more research is needed, and particularly more randomized control trials needed. And especially in in-hospital cardiac arrest, if you use the ECPR, there is a 37.9% survival rate will be there. In that, with the positive neurological outcome is 84.4%. That's so we can we can maintain normal flow circulation if you start ECPR compared to conventional CPR. So the survival rate of out of hospital cardiac arrest patient who receives ECMO span is 6% to 56%. This variation, especially due to the criteria across the selection criteria across studies. So this is the difference due to the selection criteria. So still cons of the ECPRs are still there's few questions are still not answerable. It is the starting phase in fancy we can tell it as, and researchers are still investigating specific clinical characteristics like lactate level, serum lactate, etc. ECPR still they have a whom to give the ECPR, who doesn't require means indications, and selecting the patient is still there is a valid criteria is not there. So ECPR, it's a complex, highly specialized treatment that requires more resources and staff support, and standard CPR efforts alone it won't be possible. So we need to be trained, skilled, and ready to cannulate a patient in a high risk environment. If we cannulate a patient who is eligible for ECPR at earliest as possible, then the outcome will be more good. It is ideally if we can cannulate within 60 minutes, it will be good to the patients, and neurological outcome will be good. Right. So what are the adverse effects? ECMO is itself an invasive procedure. As I said, the main complication is the bleeding and the limb ischemia. High chances are there, and potential complications like vascular damage will be there. So what are the evidence we have in support of ECPR compared to conventional CPR? For the past 10 years, ECPR is like using, and it's all about the case reports and observational studies. Some results are encouraging. And no, till now, there is no randomized control trial comparing ECPR with conventional CPR. Till date, no published. And evidence from systemic review of the available observational studies are conflicting. So, like overall, a short low flow time means like if you do early cannulation has been consistently associated with improved survival. So early cannulation will be more useful like compared to delayed cannulation. In an effort to reduce low flow time, commencement of ECPR in the pre-hospital setting has been reported and is currently under investigation. So like if you usually like in few centers like in ER they're doing the cannulation, but in most of the centers in India are doing the ICUs or in cath lab under CM thing. So if you have enough like manpower, if you train properly, if you do in ER, if you extended the same thing by the EMS at the side, there is high possibility in the outcome, good outcome. So the provision of ECPR service, it's like a considerably cost and technical challenges are there. And despite this, despite increased adaptation, which patients and when and where to implement ECPR, optimal post-arrest ECPR care, still it is debatable. And result of ongoing trials are awaited to determine whether compared to conventional CPR, ECPR is better or not. As I said, like it is like indication what like we'll choose the patients if the patients have initial rhythm like shockable rhythm. There is a high probability if you resuscitate properly, and if it is cardiac resistant to the conventional CPR, if you start the ECMO, there is a high chance of improvement if the patient has initial shockable rhythm. But in this study, like this article is published in International Journal of Emergency Medicine, it shows the character pseudo pulseless electrical activity. Like usually if we use properly ultrasound during resuscitation, we can make it out the pseudo like pulseless electrical. Like if you identify, if you resuscitate well in this patient, there is a like good outcome will be seen. This is the first trial regards to the ECPR is the arrest trial. It is a prospective randomized single center trial. It shows a survival to the hospital discharge rate. 42.9% of patients survival to the hospital when use ECPR. Compared to conventional CPR, it is 6.7% only. So these are the 4 trials, like arrest trial, as I said, previous is the first trial, and in these 3 trials are single center, and almost these trials are like cannulation is within or around 60 minutes, means 1 hour. All the most of the patients have initial shockable rhythm, but like compared to conventional CPR, ECPR is better as this study says. But this is there is an insection trial, is a multi-central trial, and it is like cannulation is more than 60 minutes, more 1 hour, but initial shockable rhythm. But still, it shows this inception trial shows similar effect on survival with favorable neurological outcome, whether it is ECPR or conventional CPR. But recent published in Artificial Organs, this is a meta-analysis of 4 randomized clinical trials of 433 patients. The results were like if like out of hospital cardiac arrest patient with shockable rhythm, with the use of ECPR, there is a good outcome with favorable neurological outcome in adults. So this is how if you use out of hospital cardiac arrest rhythm shockable rhythm with bystander goods bystander CPR and continuation of the resuscitation effort. If you use the ECPR, there is a high likely like a favorable neurological outcome with neuro. This article shows like a time frame, like if you early cannulation of the patient for the ECPR, then there will be better outcome. This direct proportions. Even in circulation generals, like 2 to 3 circulation generals, especially pediatric patients, compared to conventional CPR, ECPR is superior. Conclusions. So what are the take-home homes? What does all this means for ECPR? So ECPR can offer important benefits compared to the conventional CPR. This is particularly true in hospital cardiac arrest. And with study demonstrating ECPR clearly shows promising results, promising outcomes, and is worth continued research, discussion, and consideration as a treatment modality of cardiac arrest. Good to have, like, good to know, like, we need a lot of research about ECPR and use of ECPR in a targeted patient, so that we'll get a like good outcome. So continued research is essential to better inform us ECPR is cardiac arrest, and what patient characteristics should be considered for inclusion and exclusion. If you delineate it, if you categorize it, which patients benefit most of ECPR, if you do that, there is a better outcome and use of ECPR technique in those patients. How can responders better support OHA victims who receive ECPR? It's important to consider out-of-hospital cardiac arrest specific solution, as the out-of-hospital setting is a less controlled environment. So we need to consider all these things, and we need to select the patients properly, and some criteria like what we defined, and early initiation of ECPR will be beneficial. And with more barriers is available and rapid implementation. So successful ECMO cannulation during a high risk emergency event requires, especially we need like every person in in the resuscitation team, they should know they have to undergo training, and adequate staffing needed, and resources, whatever the equipments or whatever the things were needed for the resuscitation with ECMO, connection of ECMO CPR, VA ECMO, and so on. So hospital with an ECPR program should be prepared to properly train and equip responders to ensure that intervention is streamlined, well integrated into the overall code response, and as seamless as possible. So this is how, if you do proper identifying the patients, and early mobilization of the team and early cannulation will be beneficial. So that's how we can resuscitate a patient more than routine conventional CPR. If you use the eCPR, then definitely there will be a better outcome, and selection of the patient is prime important.
Yeah, if you have any questions, you may post it in the chat box. Or you can also use the QA section to post your questions. So what do you think of Indian scenario? When do you think we can use something like eCPR?
So nowadays in our settings, most of the time we are identifying in hospital, especially in hospital cardiac arrest. We are identifying and categorizing the patient and mobilizing for the ECPR, especially under C-arm in the cath lab. So we can do only the thing is we need to aware our staff what are the candidates eligible for the ECPR. So when we need to activate the ECPR team.
Yeah, in Indian scenario, when we have a non-favorable outcome, say someone just comes in gasping state and we fail to save that person, the family will be very much reluctant to pay even the consumables charges. For example, each hospital has a policy. Some hospitals charge only the replacements, like whatever they've used, the consumables, they will be asking them to replace. And some hospitals don't charge. Good thing is Yashoda actually doesn't charge for failed resuscitations. So each hospital has these, but if you ask them to pay any money when the patient is not saved, so they'll be very much unhappy and furious. And when you want to open an ECMO circuit, just to open and start, it is going to incur about 2 to 3 lakhs, I guess. So in that case, I'm not sure how successful it will be in India, especially.
But in inpatient, if you know the reversible cause, if it is evident that is acute MI which leading to the arrest, there is a minimal percentage of approval from the event attenders, and they can accept, I guess. We can, but we in few centers, in our center also, we did 2 ECMOs, inpatient collapse in the ER. That neurological outcome was good and discharged in a week of admission post PTCA. So in those cases, maybe it will be helpful. If you cannulate early itself, then there will be a good, it will be good results.
Okay, we have some questions. Duration of ECPR, like how long we can use it?
So we need to continue the resuscitation effort until after connecting to the ECPR, we need to know the flow of the blood. If the flow is proper, and we continue that resuscitation until unless reversible cause identified and correct. So if you correct the reversible causes, there is a high chance of getting the ROSC, and we can think about the stopping of ECPR at that point of time.
And another question is, when do we say ROSC is achieved when using ECPR?
That's what if you identify the reversible causes, slowly we can taper that flow, and we can assess the response of the patients after correcting the reversible cause.
And how can we use ECPR in cardiac arrest patients, especially in ED?
We need to see the eligible criteria, as far as we have that by good in the collapse, if the patient collapsed in the ED, if the patient has no much comorbidities, if you're not getting the ROSC after 15 to 20 minutes, then we need to think about to connect to the ECPR and continue the resuscitation with the ECPR and return.
Yes, mostly the challenges will be training of your staff and the cost aspect. How many will be willing to accept those costs, and how fast you can secure those lines, and availability of machines. Luckily, or unlucky. So we had COVID that required ECMO in many patients. During that time itself, many hospitals have acquired ECMO machines and got their personnel trained and all. So that is one favorable thing when it comes to ECPR, so that every hospital is almost ready. But again, ER preparation and cost, those two things I think are still roadblocks. So normal CPR should be done how long, and how many CPR cycles before declaring death?
So when we are dealing a cardiac arrest patient, and we are started cannulating with ECPR, we need to continue the resuscitation effort unless till normal flow. We need to see the normal flow in the ECPR and continue the resuscitation. CPR should be continued. If you get a good flow, then if you identify the reversible cause, then we can even slowly stop the CPR. We will get the ROSC after continuous flow.
So the AHA has some guidelines on, if you're asking about the normal CPR, AHA has some guidelines. As if you keep on getting the shockable rhythm, you can continue CPR. But if it's non-shockable rhythm and beyond 20 minutes of CPR, if you don't see any cardiac activity, you can stop it. Also, it also depends on the comorbidities of the patient, age. So the younger the patient, the chances are more, and it all depends on your own judgment also. If someone has multiple comorbidities, maybe in 10-15 minutes, you can take a call.
If you are planning for CPR, we need to do that. We need to assess the eligible criteria. So if the patient is old and the patient has comorbidities, better we have to think about ECPR to connect them.
Okay, for ECPR to be effective, we also will be needing mechanical CPR devices. So the CPR compression should be continuously done, and oxygenation part, it is only taken care by the ECMO. So those two things are different, and both should be on. So if you don't have a mechanical CPR device, then there's no point.
And we can think the flow, if the good flow is there in the ECPR, means VA ECMO, that is more than enough continuation of the that part, CPR, proper CPR. So at that point of time, if you have good flow and the ECMO is working well, means we can try with the stop, even we can stop the CPR also. External CPR, cardiac compressions.
Okay, any more questions? I don't see any in the chat box. Okay, then we can close the session, and you can actually get subscribed to our Telegram channel, that is MedMeet, to get notified about future sessions. I'm typing it in the chat box. And thank you so much, Dr. Sridhar, for sparing your time. And the topic you have chosen is very much interesting in the current scenario. Thanks for joining me.
Thank you. Thank you, Dr. Naveen.